Is there any early indications at diagnosis which can predict who's going to progress from stage 1A to advanced stage?
There's a really old landmark trial from the 80s that looks at people, which are very few in number, 2%, that progress after early stage disease. They tended to be older patients and patients who did not respond to their first treatment modality.
I would agree with that. There are sometimes histologic uh, features on the skin biopsy, something called large cell transformation, which is something that's observed on the pathology report that sometimes can indicate worse prognosis. And I agree with the more like diagnosis at an older age. Dr. Pinterbrand, do you have like what that older age would be?
No, I'm trying to think in that paper. I want to say, sadly, it was in the 60s. It's an old paper. I haven't read it in such a long time, but I vaguely remember in the 60s.
Do you believe that younger patients often initially present and remain at an early stage of the disease for decades due to their immune system quickly identifying and containing the harmful T cells? Or is it more of a characteristic of the nature of mycosis fungoides itself?
It's probably a combination of both, I would have thought. In terms of the younger type of mycosis fungoides, usually the type that we see in younger patients is the hypopigmented, so that's underpigmented patches on the skin, and usually that's got a very, very good outlook. And then there's been questions over the last few days at conference whether we need to relook at the hypopigmented mycosis fungoides as a lymphoproliferative disorder as opposed to a lymphoma, because they tend to do quite well. I think in terms of the role of the immune system, it's very, very important because our immune system is there not just to fight against bacteria and viruses, but also if any of our cells of our body misbehave, then our immune system is there to keep those in check. And I think that a healthy functioning immune system has got a very important role in keeping that immune system or anything that's trying to misbehave and keep it under check at all times.
Can initiating treatment early alter the trajectory of the disease, or is the course already predetermined regardless of the early treatment someone receives?
I think about this all the time, and I think that the only answer I keep coming to is that we don't know. And I think the Proclippy study, the prospective study that some of you may be involved in, looking at the markers in terms of the patient and also the disease itself, and actually also importantly therapeutically, is what does that change the natural course of the disease over time, and following that and to see where the risk is in terms of disease progressing, and are there any therapies that might actually alter that course, and also stratifying patients that might be at higher risk of progressing to more aggressive disease and treating them early in aggressive disease that change the overall outlook for people that are affected by it.
Yeah, I think in other subtypes of kind of chronic lymphomas, we've shown that treatment early doesn't necessarily alter the course of the disease, and so I think going from that, I might presume that early treatment wouldn't necessarily alter the course of the disease, but I think that there are, some subtypes or some features that, may predispose somebody to having it grow, and, I think that's something that we do need to understand using things like Proclippy and other resources.
Are there any valid mortality tables at this point in time regarding the various CTCL diseases and various stages of each? If not, are there plans to update them? Do you find that such tables help or hinder patients?
So there are there have been surveys looking at life expectancy and trying to understand that. I do think that there have been some novel therapeutics that have been more widely used in the past few years. And so, I think that's something that's being tracked, I think in prospective registries like Proclippi. That is one way that we can kind of track that and understand that. As far as whether or not it helps or hinders a patient, I think it depends on the patient. Some patients really really want numbers. Some patients don't. Sometimes caregivers want numbers and patients don't. So I think it really kind of depends on the particular patient. One thing that I would keep in mind, though, is that regardless of what the numerical breakdown is of something happening, it also really just depends on you. So if something happens to 50% of people, but it doesn't happen to you, it doesn't really matter because it didn't happen to you. And so I think when we see patients, we are sort of aware of these kinds of numbers, but we're also really focused on that specific patient and what we can do to help that specific patient. So, it can be both, I think.
How often does someone with stage 1A progress to more advanced disease that may become life-threatening?
I can take that one. I think this depends on a lot of things. With just stage 1A disease, it can be hard to know, but in general, data is just about 10% of patients progress. And what that means is that could just mean more skin involvement for a lot of people. So that just means instead of having one plaque or kind of patch on your arm, then your whole arm's involved, or you have some on your trunk as well. Then for a rarer or smaller group of patients, so this then means something else. So I would say stage 1A disease is a very, very good prognosis. It's something that you're going to be living with for most patients. But again, this is with the caveat that there's other data that we need here to kind of assess. And this is population data, and each individual is different.
Can you talk about lifespan? My husband has Sézary syndrome stage 4-2B. Everything online says 2 to 4 years, but his doctor says decades. And I know this is a tough generalizing on lifespan, not this particular person.
So I think the way I would answer this is, again, never having met the person and not seeing the characteristics of their disease or the specifics of it, is that while it is true that the data that we have has a much talks about a much shorter life expectancy, a number of that data is quite dated, and was before a number of other a number of treatments that we have, as well as a number of other approaches. And so I think that from the point of view of, as we all know, that none of us are great at being able to predict any of this. The other thing I think to say of note is that there's all different versions kind of stage 4B, and thinking of and how that manifests itself and how it behaves is going to be an individual sort of thing. I think the other things that are not predictable is whether there is any, there's any transformation, and or, as always, one of our biggest concerns is, of course, infection. And so things like, and of course, Dr. Wallner can help me on this, but things like, a number of different approaches to keeping one's skin integrity the best it can be, and the like. I don't know, Zach, if you would like to comment on some of those.
Infection is definitely one of our biggest concerns with this, due to this disruption in the skin integrity and the role a staph plays in this. So things you can do to kind of decrease the amount of staphylococcal load is, like, we recommend this for kids with eczema, because this often has a similar staph kind of disease interplay, which is it's called bleach baths, which sounds horrible, but it's essentially creating a swimming pool in your tub. That's one option to decrease staphylococcal colonization. If you're not a bath person, you can do a kind of recreate one in like a little tub. Not tub, what am I trying to say? Bucket. And then just do like a sponge bath with this. And that's, again, just something to try to decrease the amount of staph. And then following through with your treatment is once you get less disease activity, the skin will kind of begin to heal and have less kind of cracks and breaks, allowing for staph to enter. But I think the main important things, if you have fevers, chills, and so has any concern about a potential kind of infection, to let your doctor know immediately.
Does treatment halt progression or just help symptoms? And that is a very broad question because there are many types of treatments. So I'm not sure how you want to tackle this one.
I would say our goal is to get remission as well as treat symptoms. Whether or not this will delay progression or stop that is not certain as far as I'm aware. I don't know if Mary Jo has additional insights, but our goal is to get things clearer and also feel better. I would say it also depends upon what your goals are as well. So again, in certain cases, getting things entirely better is not necessary if your goal is just to make sure this has less impact on your life.
And that just to underscore, I think that is a very individual conversation in terms of there are some patients that want that only the best possible remission is is the answer. Others are content with occasional skin flares, but are able to do things in life that they weren't able to do for a number of years. And there is such a wide range with regard to what people are willing to have as their everyday new normal.
What test do I need to undergo to determine if I progressed or developed another form of CTCL? Dr. Girardi, if you want to take this one.
Yeah, I think this is a great first question. CTCL is really a cancer of the skin, but also the blood and the lymph nodes. So testing around progression from where you started and changing to a different form is around reevaluation of those compartments. So for the skin, that starts with a full body skin examination with a dermatologist who specializes in cutaneous T-cell lymphoma. It may require multiple skin biopsies, even if you've had them before, because sometimes the cells change and their tropism, what part of the skin they home to, changes. It may involve blood testing again, especially flow cytometry that looks at all the different types of T-cell markers to evaluate whether there's been expansion or involvement of the blood. And then to evaluate the lymph nodes, the standard most informative test is a full body scan, a special type of CAT scan called a PET CT scan that is so sensitive in looking for any type of involvement with lymphoma inside the body, especially the lymph nodes, but also any organ. So those are the full range of tests to work up for that.
For patients who have maintained early stage disease for long periods of time, have you found any connections between treatment strategies or lifestyle factors that you would advise us to follow? So it kind of ties into the last one, Dr. Girardi, if you want to take a first stab at this.
Sure. I think, stage 1A, less than 10% of the surface area involvement with patches. Stage 1B could be over 10%, but we've had patients who can maintain remissions or close to remissions for decades with those stages. They tend to have positive attitudes, tend to be plugged into the healthcare system, work with the doctor very closely, communicate effectively, and follow regimens and be willing to change regimens as we move on. They tend to be healthy in other ways, so making sure that they are doing what their primary care physicians may recommend in terms of controlling other health concerns, from diabetes to hypertension to hyperlipidemia and hypercholesterolemia. They tend to exercise. They tend to stay motivated and keep on going. They also tend to come to meetings like this. That's about being educated as a patient, It's about sharing experiences sometimes with other patients. And I think that these are personal connections that are also very important to the longevity of a response.
I have CTCL and was told by a dermatologist I saw there is no way to confirm that the cancer is in remission except visually. Has this been the case for either of you? How would you go about determining if someone is in remission? Not sure who wants to take that one first.
Well, I can take a stab because I feel Dr. Wang has been answering a lot of the initial questions, but I think I talked earlier about how cutaneous T-cell lymphoma, while it's mainly affecting the skin in the majority of patients, it really is what we call a multi-compartment disease, and it can, in some patients, affect the blood, where we can measure it. By, for example, flow cytometry. It can affect the lymph nodes and the inner organs, and this is usually measured by either PET scan or CAT scan. So these are imaging modalities for patients who have not only skin, but also blood and or lymph node or organ involvement. The skin we do assess really, truly, mainly by visual scale. Where we measure the amount of body surface area that is affected by the CTCL, and then we also measure whether it is a patch or a plaque or a tumor, and then assign a score to it. So if there is a tumor, it gets a higher score than if there is, for example, just a patch. In some patients, of course, also the lesions can be sometimes difficult. It's not always a red patch, especially people with skin of color. It can be sometimes difficult to determine. Patients can present with just hyperpigmented or hypopigmented lesions. There are, say, some very rare subforms of CTCL, like granulomatous slack skin disease, where it's really not visualized as a skin change itself. But usually, in general, again, it's determined visually. Very rarely, if there is doubt on a lesion that may or may not look like an active lesion, a biopsy could determine. But given that it is an incurable disease, we know that remission, achieving a complete response is, in a way, while reassuring, we do know that there probably are at some level that we may not detect even by the most sophisticated methods. There are some areas that are affected by the lymphoma that we may not even see. And it probably does not influence how somebody is doing later on, even if there are some what's called microscopic disease areas still remaining.
Yeah, I'd echo what Dr. Barta says. I think it is very challenging, even though it's a visual disease, it's on the skin. There's really not a great way to determine if someone truly is in remission, because not only can disease be subtle, not every patch is a bright red scaly thing that you can see that itches. It can show up later on in time, and I think the main thing to emphasize is that for many cases, particularly if it is just patch or plaque and mycosis fungoides limited to your skin, it does tend to follow an indolent course. So while not curable, very manageable, it shouldn't affect someone's lifespan or longevity.